You can hear me? Yeah, good. Okay. All right. Thanks everybody for joining us. If you've never been with us before, then thanks for coming. And for those of you who've joined before, this is our third in a session of webinars related to spinal cord injury and various health topics. So the first one we did in, I think, April or so was related to spinal cord injury and COVID-19. And then the second one we did was related to virtual care in, I think, July. So we're really happy to be able to have this one on pregnancy and spinal cord injury and accessible care clinic. We're really happy as well because this is something that people chose out of a poll that we did after the last one. So this is not something that we necessarily dictated, but everybody else did. So there's a real interest in this. So my name is Jamie Milligan. I'm a family doctor in Kitchener-Waterloo, and we run a mobility clinic involved with the Ontario Neurotrauma Foundation and Praxis in trying to help individuals with spinal cord injury and other physical disabilities access primary care better. And we sort of have been organizing these webinars. So we'll just get, I'll just talk a little bit about some housekeeping stuff. So I think most people are probably quite familiar with using Zoom, but if you do have any problems, just contact Lindsay out of a previous email that you would have. The other thing is please mute yourself if you're not speaking so that we don't have a lot of background noise. There is a chat function, so feel free to ask questions or comments in the chat. Dr. Berndl is going to perhaps take a pause halfway through her presentation to maybe answer any questions that might be there. Otherwise, she will answer at the end of things. And that would be about it. We'll do a little bit of a wrap-up talk at the end, a few announcements and that type of thing. But without further ado, I will just introduce Dr. Berndl then. So Dr. Ann Berndl is the director of the Accessible Care Pregnancy Clinic at Sunnybrook Hospital. She is a maternal fetal medicine specialist and assistant professor in the Department of Obstetrics and Gynecology at the University of Toronto, and is an associate scientist at the Sunnybrook Research Institute. Her clinical and research interests focus on obstetrical care for people with physical disabilities. So we are extremely delighted that she was able to do this presentation, and we think it's going to be great. So I'll turn it over to you there, Anne.
Well, thank you so much for the kind introduction. The topic, as you introduced, I would like to speak about today is pregnancy in people with spinal cord injury. So I'll focus a little bit more on spinal cord injury and the Accessible Care Pregnancy Clinic. So what I want to discuss is how and why we created the Accessible Care Pregnancy Clinic. I want to talk about the impact of spinal cord injury on pregnancy and pregnancy on people with spinal cord injury. So sort of to look at it from both sides. And then I'd like to do an overview of how antenatal care is provided at the Accessible Care Pregnancy Clinic, including labor and delivery. So what do we generally know about people with physical disabilities and pregnancy? So most people with physical disabilities have normal fertility, are able to get pregnant, and can have a vaginal birth. So just, from the get-go, lots of good news for people with physical disabilities who are considering pregnancy. More people with physical disabilities appear to be choosing to become pregnant, so this is happening more commonly. However, there are, of course, a number of barriers and challenges that people with physical disabilities face during pregnancy. And it's been found that negative attitudes by healthcare professionals is one of the most important barriers that people face when trying to access healthcare. And this was an important component when we were establishing our clinic to be aware of these biases that are present. So essentially, we know that we have a high healthcare needs population, and there are multiple barriers to those people accessing care. So this was a very clear clinical care gap. So when we were developing the clinic, we wanted to do it in a person-centered manner. So we started by doing interviews with mothers with physical disabilities, people who had recently had babies. This project I did with Dr. Gareed Bekdek, who's another maternal fetal medicine doctor. She's at McMaster, and she's a wonderful person. She actually did interviews in 3 different languages, and she got some insight in terms of what is really important to people during their antenatal care. We also wanted to speak to leaders in the disabled community to find out about what was felt to be important components of providing antenatal care to people with physical disabilities. And from that, we developed essentially our pillars of care, and we wanted to really make sure that we were staying true to these while we were providing care at the ACPC. And so those were respect of each person as an individual, so not lumping all people with physical disabilities together as if they all have the same concerns during pregnancy. Consolidation of care was seen as a really key component. Some people just talked about their experiences of needing to go to many different appointments during the week, so it taking up all of their time, or even going to different hospitals on the same day, which is very challenging. So we wanted to try to bring everything together as much as possible. Excellence in communication, and this meant not only between us in the clinic and the people who are attending the clinic, but also really good communication for the whole team, because many of these people had an interdisciplinary team during their pregnancy, and evidence-based practice, which of course is a challenge in that there's not a lot of data about care for women with physical disabilities during pregnancy. So one of the first things we did to try to address some of the healthcare provider bias that we know is real is we had a training session with Dawn, which is the Disabled Women's Network. And it was really important to us that we didn't just invite the physicians and nurses who are participating in the clinic, but that all people who would have any contact with the people as they were coming in for their antenatal care also underwent this training, because we wanted this to be a really positive experience when people came into our clinic. So, you know, our administrative assistants attended, the sonographers attended, we had students who were attending, you know, essentially anyone who might come in contact with the patients coming in were invited to attend this training session as well. So I'm going to shift gears and talk a little bit specifically about women with spinal cord injury and what the specific healthcare concerns are during pregnancy. We like to look at these sort of healthcare concerns both for things that might affect the woman maybe inside or outside of pregnancy, so things that are affecting her body. Then looking at things that are pregnancy specific, so conditions during pregnancy that we might need to manage differently, and then also things that might affect the fetus or the baby. So the things that women might be experiencing, so some of the maternal concerns, bladder infections is a big worry, kidney infections, septicemia, which can be a sequelae of those. Autonomic dysreflexia is a major concern for people during pregnancy. Skin changes, some people do notice significant respiratory changes during pregnancy, and VTE is of course a concern. And some women do notice they have increased spasticity as well. There are pregnancy-specific concerns for women with spinal cord injury during pregnancy. So there does appear to be an increased risk of preeclampsia. Women with spinal cord injury appear to be more likely to have a cesarean section than people without a spinal cord injury. There is a risk of preterm labor and birth, both from contractions as well as having the membranes rupture early. And it looks like there's also an increased risk of postpartum depression in this population. There are some concerns for the baby as well. Preterm birth, of course, can have sequelae for the baby. Babies of women with spinal cord injury appear to be more likely to be small for gestational age, and they're also more likely to be breech or malpresented. So when we're providing care for women with spinal cord injury, as well as women with other types of physical disabilities, we really need to focus on an interdisciplinary team. So of course, their primary care provider, who hopefully knows them well, maternal fetal medicine, so someone like myself, and I really do encourage a preconceptual consult. So if someone is considering pregnancy, to come and talk about what that might look like beforehand. Often there's a neurologist involved, anesthesia is involved in pretty much all of our cases. And then there's a number of other people who might be involved depending on the individual. So lactation consultants, dietitians, physiatry, OTPT may also be part of the team. So what are some of the major concerns during pregnancy? You know, bladder and kidney infections is really up there. When we're looking at the risk of acute cystitis and pyelonephritis in women without spinal cord injury compared to women with spinal cord injury, you can see that there's a huge difference in the risk for these different individuals. So from having an acute bladder infection in pregnancy without spinal cord injury, 1 to 4%. However, 64% of women with a spinal cord injury, and from the small studies that have been done, it looks like all women, once they have an indwelling catheter, do end up with a symptomatic bladder infection at some point. Pyelonephritis is another important one to think about, in that women who do have spinal cord injury also appear to have significantly increased risk of that. There's a reason we care so much about bladder health in pregnancy, and that's because it can have impact on the pregnancy itself. So we do worry about it in terms of women without spinal cord injury as well. So if you're having bladder infections, they can lead to kidney infections, renal dysfunction, and long-term renal dysfunction. When you don't have a spinal cord injury, the risk of actually developing pyelonephritis and ongoing renal dysfunction is very, very low. But if you do have those sequelae, they can have an impact on the pregnancy. So not only admission to hospital and concern about kidney injury, but the kidney injury itself can increase your risk of preeclampsia. Having kidney infections during pregnancy increases your risk of preterm labor and birth, and it can also increase the risk of cerebral palsy. So it is an important thing to notice and treat. We care more about this in women with spinal cord injury in pregnancy because the prevalence is so much greater. And so we do know that in women with spinal cord injury, there is this increased risk of preeclampsia and preterm birth and smaller babies. We don't know for sure if it's because of the increased risk of pyelonephritis, but it appears that's a likely contributor to it. And then there's also other spinal cord injury specific concerns that would come along with that. So then there's that increased risk of autonomic dysreflexia, and then the change in bladder management. So for example, if they end up needing an indwelling catheter, they can have other risks of worsening infections at that point. So what do we do for bladder management in patients with spinal cord injury during pregnancy? The problem is we don't really have good management. There's nothing really evidence-based available right now. The method that we usually use at this point in time, because we don't have any really good evidence-based practice for it, is that we do very close screening and then treatment. So we'll screen people about once a month or so for a bladder infection, and then we'll treat it. And the reason that we do that is that we know that even the asymptomatic bladder infections can increase the risk of preterm birth. This is a challenge because we know that there's a lot of people who have spinal cord injury who just have chronic asymptomatic bladder infections. And so there is likely going to be a lot of treatment that's going on. But we don't really have good evidence one way or the other at this point in time in terms of which way to go. Another concern for some people with spinal cord injury is restrictive lung disease. So we don't, again, have really good guidelines in terms of when we're going to be testing. So I worked with Dr. Anu Tandon, who's the respirologist here, who sees most of the women that come through our clinic. And we've decided that at baseline, for anyone who's using a wheelchair or has other symptoms, we should be doing at least one pulmonary function test at 28 weeks. And that's just to help for labor management and anesthesia and help detect any concerns early. And sometimes people need follow-up visits. If people are having concerns with restrictive lung disease, it can be an indication for preterm delivery, depending on how severe it is. Autonomic dysreflexia. So this is a major concern during pregnancy as well as outside of pregnancy. But there are a lot of things that happen during pregnancy that can be triggers for autonomic dysreflexia. So labor and delivery itself, so contractions, having your water break, those sort of things can trigger autonomic dysreflexia. Bladder distension, so associated with If you have a blocked catheter and you end up with bladder infection, or a bladder distension or infections, those things can trigger it, of course. Constipation. The examinations themselves can trigger it. So if someone's checking to see if they're dilated, that examination could cause autonomic dysreflexia. DVT, of course, surgery such as a C-section, so that could trigger it. And breastfeeding has also been associated with triggering autonomic dysreflexia. The reason why it's important to make note of in pregnancy is not only are there more triggers, but the clinical overlap with preeclampsia is significant. So preeclampsia presents as high blood pressure, headaches, changes in the visual field, such as blurred vision or spots. So this is all very, very similar to autonomic dysreflexia. People with preeclampsia also sometimes have nausea and vomiting. So there's quite a bit of overlap. And the sequelae of autonomic dysreflexia and preeclampsia are both severe. So they can be a stroke, death, kidney injury from preeclampsia. So it is something that's really important to recognize and treat. Because of the similarities, it's good to have an idea of how can you differentiate these two really important presentations. Autonomic dysreflexia, of course, tends to come on much more quickly and is associated with normal labs. Preeclampsia can come on very, very quickly, and I've seen it evolve over, the course of half an hour in some individuals when it's severe, but sometimes it grumbles along for a period of time and slowly builds up, which would be very different than autonomic dysreflexia. And some people, their preeclampsia slowly builds over even a period of weeks. As well with preeclampsia, there tend to be lab abnormalities as well as proteinuria. So there are some ways to differentiate between these two. So let's talk about labor, preterm labor. So women with spinal cord injury do appear to have an increased risk of preterm labor. And this has been seen in some larger studies where they're doing a retrospective review, as well as in some Canadian case series that we see that there is an increased risk of preterm labor and delivery. Because of this increased risk, there have been some people who have suggested that we start doing serial vaginal examinations as we enter the third trimester to see if someone is starting to dilate. And that's because there are some things we can do to decrease the risk of preterm labor and also to help prepare the baby in case the baby is born early so that they have not as much concern from a respiratory perspective, such as administering antenatal corticosteroids. There's not evidence that, as a lot of the management here, there's not, really clear evidence or guidance that we should be doing this routinely, but it's something to consider. So anyone who has any sort of suspicious symptoms, we're going to be checking their cervix. Another concern, so not only are women with spinal cord injury at higher risk of preterm labor, but they may not be aware that that's what's going on. So sometimes when people are in labor with a spinal cord injury, they have different sensations. So some people have found they have pain above the injury, some sort of abnormal sensation, more spasticity, bladder spasms. Some people do present with autonomic dysreflexia when they're in labor. Sometimes they'll just notice that they're very wet, so that their water has broken, or they have no symptoms. And so we try to encourage women to palpate their abdomen. So to just get used to putting their hands on their belly and feeling if it's getting hard, if they're noticing any changes that are there, to assist in detecting labor. Another important part of labor management is the consideration of induction of labor. So there's a couple different reasons why it might be appropriate in some people to consider an induction as opposed to awaiting spontaneous labor. So one might be transportation concerns. So if arranging a wheelchair transportation, if you don't have access to your own wheelchair accessible vehicle, that can be a challenge. It'll be very difficult to organize that in the short term if you're sort of in an emergency and you think you're in labor and you need to go to the hospital. If you call 911 and get an ambulance, they will take you to the nearest hospital, which may not be the hospital that you are planning to deliver at. So for some people, the idea of the transportation concerns is real, and that's something to think about in terms of planning an induction. Some people may not be able to assess if there are contractions, and then a concern about a precipitous delivery in outside of a hospital location, or for example in a vehicle because they didn't know that labor had started. The risk of autonomic dysreflexia. So if you want to mitigate that risk, then you can bring someone into the hospital, plan for an induction at term, administer an epidural to decrease the risk of autonomic dysreflexia for that person, and then induce them. So that can be a very safe way to manage it, and keep the mom and baby safe during labor. And this would be something that you would discuss with the person on a case-by-case basis. This would be an appropriate plan for them. In terms of the labor management, we would consider the induction versus spontaneous onset, based on their history and their risk of autonomic dysreflexia. If they do have a high risk of autonomic dysreflexia, either because of a personal history or because of the location of the lesion on their spine, the recommendation is that they have continuous hemodynamic monitoring during labor, and that can include an arterial line, and we would want to have continuous fetal heart rate monitoring during labor. We'd want to prepare with our antihypertensive medications by the bedside, have really good communication with the team, so anesthesia would be aware, the nursing staff would be aware, labor and delivery management team aware. And then when we're doing exams, we should be using a lidocaine jelly, as well as with the catheterization, to decrease the risk of triggering autonomic dysreflexia. So when would we be doing a C-section versus encouraging for a trial of vaginal delivery? So one could be, of course, for obstetrical indications. So there's a lot of reasons why anyone might require a C-section. People with spinal cord injury are at greater risk of breech presentation, and that's a pretty clear indication for a cesarean section. For preeclampsia, so if someone develops severe preeclampsia and we don't have time for an induction, then a cesarean section is at times the right way to deliver that baby. Or obstructed labor. So it does appear that people with spinal cord injury are more likely to have obstructed labor than people without spinal cord injury, and that would be another obstetrical indication for a C-section. You may also need to do a C-section to treat autonomic dysreflexia. So if someone is having autonomic dysreflexia and it's from labor and you're not able to manage it with the epidural is not adequate, then we really need to just rapidly deliver the baby so that the person stops laboring. And if the person is already fully dilated and pushing, we can help expedite delivery with forceps or vacuum, just so that the labor has ceased. But at times you might need to do an emergency C-section. And also for maternal choice. So sometimes people just feel more comfortable after discussing their risks and benefits. Some women do choose to have a cesarean section, and I support women's choice surrounding mode of delivery. So breastfeeding with spinal cord injury. So we know that breastfeeding, there are benefits for mom and baby, but in people with spinal cord injury, there is quite a low rate of breastfeeding. One study that I found, it was only about 11% of people with spinal cord injury were breastfeeding, but there's a lot of concerns that some people have. So one is actually triggering autonomic dysreflexia. So almost 40% of people with the injury at or above T6 did experience this, and so that would be a real disincentive to be breastfeeding. Some people find it challenging to get a good position, some challenges with latching, and some people also do have challenges with milk production as well. So people with higher level injuries were more likely to have insufficient milk production or a letdown reflex. There have been some suggestions of using mental imagery and relaxation techniques that can help with letdown, and even use of oxytocin nasal spray. Right now, the oxytocin nasal spray is not anything that we're making use of, or that the lactation consultants that I work with have been recommending, but you'll see it in a few case reports. And often we'll collaborate closely with the lactation consultants for women who are hoping to breastfeed so that they can prepare beforehand. Postpartum depression. So about a third of people with physical disabilities have postpartum depression. For people who do not have physical disabilities, the risk is about 1 in 6. If it looks like the person has a history of depression or anxiety, or you feel that they're at risk, it probably makes sense to refer the person early on to mental health resources. We have some really good reproductive health, mental health resources, and I'm sure there's many other people who are helpful and qualified to provide that. But the early referral can be really beneficial, because once that person's gone home and they have their newborn baby, there's a lot that's going on, and already having some support in place is helpful. Usually for screening, we use the Edinburgh Postnatal Depression Scale, but it's not been validated in people with physical disabilities. So I'm just going to take a little break there before I talk about what flow through the clinic looks like, to see if there's any questions. I was just trying to run through some of the concerns that we might have for people with spinal cord injury during pregnancy.
Thanks, Dr. Brendel. So if anybody has some questions and wants to voice them, or if we use the chat.
I'm so sorry. I just can't, I can't hear you. Any questions?
Anne, I did have a question. Can you hear me?
I can hear you. Sorry, you're very quiet. I think it's on my end. I think my speaker's not so great.
Oh, okay. I just did have a quick question. You know, we use domperidone quite a bit in primary care for, you know, decreased lactation supply and that sort of thing. I wouldn't have any idea of its use in people with spinal cord injury. Would there be any issues with that and some of its associated side effects that you'd want to be careful with?
So sorry, you said you used domperidone.
Just in a regular, like in primary care, you know, with lactation issues, we'll sometimes use it. I'm not sure in SCI if you'd want to be concerned with some of the risks with it at all.
So, so the domperidone, I myself don't usually prescribe it. I usually go through the lactation consultants if it's something that they think is beneficial. There have been some women, I can't remember specifically if they were women with spinal cord injury or not, to be honest, who have used it postpartum. So I think that, as far as I know, I don't, if there's any concern with it with people with spinal cord injury in of itself, but it is something that some people do use postpartum.
Thanks. And I see there's a question about how does physiotherapy integrate into your clinic, and do they do internal pelvic floor PT at your clinic? And I'm not sure if that's something that maybe you'll end up covering in the next part.
Sure. So I'm happy to just answer it now. One of the big challenges that we have with our clinic is that we have funding for inpatient physio and OT care only. So if someone needs to have physiotherapy or wants to see OT outside of pregnancy, we have to sort of organize it separately, which is a big challenge. That's one of the things that we talk about quite a bit, is that would be ideal. We'd love to have a physiotherapist as part of our clinic. If people, if they're admitted, we do try to get OT and PT to see them during that period of time, and it could be for a variety of different reasons. Pelvic physiotherapy is something I'm a big fan of for all pregnant women if they are having any concerns about pelvic pain, lower back pain, or bladder concerns during pregnancy as well as postpartum. So it's and women do tend to have a significant success with it as well. So it's one of the things that I wish we had our own physiotherapist that could be part of our clinic, but we can't, and we've tried and we've worked with the physiotherapists here to try to make a connection, but they were essentially not given funding to be part of our clinic unless it's on an inpatient basis. So when they're there, then we'll consult them at that point.
Maybe I'll just do one more question and keep the rest to the end there. And Terry Thorson had raised her hand. I'm not sure if you have a question, Terry.
I do. Is it okay to just unmute myself here? And can you hear me okay?
I can. I'm so sorry. This is my own technical issue, and I'm just going to stick my ear right near the speaker here.
That's okay. So obviously there's a lot of potential risks involved. How do you prepare women about these risks but not scare them?
So, you know, the thing about the risks that are there, they're not unique to women with spinal cord injury, except for the autonomic dysreflexia component, but the obstetrical risks. So when we think about risk of C-section, risk of preterm birth, risk of small babies, preeclampsia, those are things that we see and manage all the time. So it's, there are many women who have spinal cord injury who may have a very normal pregnancy without any of these complications. And then there's lots of women who don't have spinal cord injury that have many of these complications as well. So I think that, when we're doing a preconceptual consult, which I really like to do because I think it's good for people to go in with their eyes open about what's going to happen next. I talk about, what we'll be watching out for, and how we will manage it if that occurs. And that way it gives some confidence about, that these are not going to be big surprises that are coming up. We'll hopefully detect things early. And we do have a lot of risk mitigation strategies available from an obstetrics perspective in terms of managing these concerns. And I think when you go in sort of really well planned, it helps from not only just making sure we're not missing anything as we go into a pregnancy that may be more complicated, but then if those complications occur, it's not the first time someone's heard about it, and they know that it's not, that we have other strategies, and we already were prepared for this, and we know what's going to happen next. Because in the end, although there are these increased risks that are there, again, the majority of women are going to have healthy pregnancies. And even if they do have those complications, so preeclampsia, preterm birth, C-section, small babies, most of the time, those are things that they can be managed in a way that people do well in the end. So, we try to make people feel confident and comfortable, let them know that, this is something that we manage very frequently. In the high-risk clinic that I have, it's not all women with physical disabilities. We do a lot of, bread and butter maternal fetal medicine, which, to be honest, is preterm birth, stillbirth, preeclampsia, hypertensive disorders in pregnancy, which so there's a lot of experience there, not only for myself, but the clinic nurses that are there, the sonographers that we work with. And I think when they sort of see that we have a good team approach moving forward, they feel comfortable. There's very few people that I would be very worried about pregnancy and express that as a significant worry to them. It's usually more of these are things that can happen. This is how we would anticipate it. This is how we investigate on it, and this is how we would manage it if that were to happen. And I see people a lot. Like there's some people who I see, every week, every 2 weeks. So we get to know each other very well.
Okay, thanks so much, everybody. Those are great questions, and we have a couple more in the chat, but we'll wait till the end, and I'll let you go ahead and continue there.
Okay. All right. So I'll just take a little run through of sort of what happens in our clinic. The first thing that happens is we get a referral from somewhere. So someone sends us a referral, and this is a picture of Liz Young. So she's the advanced practice nurse that I work very closely with. We see our patients together very frequently, and she'll start by giving them a phone call before they even come in. And the purpose of this phone call is that we want to know, what's going on with them, who do they live with, what sort of devices, if any, do we need to have ready for them when they come in? Do they need a Hoyer lift? Who are their support people? What medications did they take? And how are they planning on coming to and from the clinic? So we just want to get a good intake, and they have a chance to ask questions of us as well. So we like to just sort of know what's happening and making sure that we're prepared on our end, especially from a timing and equipment perspective, so that the visit goes in a very smooth manner, because we're bringing women into a very busy obstetric clinic. There's a lot, often there's 2 or 3 clinics running concurrently, and we just want to make sure that it's a smooth process. especially when it comes to wheel trans. So we have a lot of people who do come to our clinic, not so much now during COVID, but prior to that, they did make use of wheel trans. So we had to make sure that people got in and out in a really timely fashion. So I'm sure you've all had some experience with wheel trans, that the timing is really key, and we don't want anyone sort of stuck or not able to get good transportation. So we work with their wheel trans timing in terms of their ultrasounds and the clinic visit. So then they check in, and again, we have spoken to all of our staff, and they've all done training, and so they're expecting to have people with physical disabilities coming through our clinic, and they know that the timing is also really important. And then they often go to ultrasound. So I'm so fortunate in that I work in a clinic that is directly adjacent to our fetal sonography unit. So it's all essentially 2 sets of hallways that we can move very freely and easily within, and we work very closely with the sonographers that are there. And I just wanted to touch base on ultrasound, and we've actually had to develop a sonography protocol because, again, this is something where people are moving through a clinic space. We want to make sure that they're comfortable. For example, getting up on the table, is that something that is working for them? Do we need extra booking time? And they're not coming just for 1 or 2 scans. So standard prenatal care, that we usually do the basic scans are a 12-week scan and an anatomy scan at the 20-week point. Most people are also doing a 3rd trimester scan. However, people with physical disabilities, and again, this is more about the function of the clinic in general, not specifically spinal cord injury, but there is an increased risk, or there are increased risks that require more ultrasound. So this is something we're doing frequently, and so we need to make sure that we're moving through in a manner that works for the sonographers as well as the women themselves. So we need to be checking the growth of the babies more frequently. Sometimes we screen the cervical length, and that gives us information about risk for preterm birth. When we're worried about small babies or preeclampsia, we need to do an assessment of the fluid around the baby, the movements of the baby. And so there's a lot of different reasons why some people have multiple scans during their pregnancy. And so this is sort of the setup that we have. We have a larger sonography room. We like to prepare beforehand. So you can see we have our Hoyer lift here. We often engage the partner or support person when we're doing the ultrasound to make sure that people are comfortable. If they have spasticity in one area, or they're very tender in one area, or difficulties mobilizing, we want to make sure that we're trying to make them comfortable during the exam. Really good communication about what's going on. We make sure that we add at least 15 minutes onto these scans. So we book them specially so that no one's feeling rushed, and it can be a good experience for the sonographers as well as the person having the scan. And we want to make sure that their wheelchair fits in the space, that's just a comfortable experience. So after they have their ultrasound, then they come into the clinic, and I have this picture down here of one of my lovely patients who sent us a whole bunch of beautiful photographs of her and her baby that we can use for these sort of things. And this is a whole bunch of people that I've been so fortunate to work with of all different disciplines. And we need to really individualize each person's care, and each person has a different type of care that they need. So for example, here's a couple of families that I've been fortunate enough to deliver all these gorgeous babies, and all of these mothers here have a different reason for having a physical disability, and they had a really different birth plan, and here they all are with their family. So we're trying to really make sure that we're individualizing each person's care. And one of the big things that we try to do, and you can see there's a little bubble there that says the Center for Independent Living, is that we get people in touch with the Center for Independent Living and applications for a nurturing attendant. So a nurturing attendant is essentially a person who will come and help with some of the physical tasks of parenting. And this is for people who qualify for attendant care, can also qualify for a nurturing attendant. So for example, if they want to give their baby a bath, and so they sort of get a certain number of hours per week, they're going to be there with their baby and parenting their baby, but maybe the lifting in and out of the bathtub is a challenge, as an example, for someone. And so the nurturing attendant is going to be there with them to help them with some of those physical tasks of parenting. It does take about a year to get it all in place, so we try to get people on this right away in terms of their applications. So after we've, had our team of people in terms of who needs to be involved in the care, and we've sort of brought them through the pregnancy with, their neurologist and the respirologist, and they've seen their lactation consultant, we have a team meeting, usually in the 3rd trimester. And one of the key parts of this is that our team meetings involve all of the care providers as well as the pregnant person and their support person. So we all sit down together and we make sure we know what's going on for this birth. And that includes, specific surrounding equipment that needs to be available for that person. We get input from anesthesia about any anesthetic concerns. And we have sort of a plan A and a plan B, in terms of what happens if someone comes in the middle of the night in an emergency, versus when we're planning that things might be happening. And the person gets a copy of that. We have a copy that goes up to birth unit. We have a copy in their chart. So just to make sure there's really good communication going into birth. And then we have a baby. So, this is I'm an obstetrician, so there's going to be some baby pictures. I can't help it. So here's a lovely newborn baby there. So one of the things that I just also want to drive home about birth is that people with physical disabilities can have vaginal deliveries, and people with physical disabilities are more likely to have a cesarean birth than a person without a physical disability. But the most common mode of delivery for people with physical disabilities is still vaginal delivery. So although they're at higher risk of a cesarean section for a variety of different reasons that we spoke, the most common mode of delivery is still a vaginal birth. So I just wanted to show you, this is our accessible birthing suite, and it's really gorgeous, and you can see our nurses so proud in showing it off. So it's really big, it's the corner office, there's lots of sunlight. It has an accessible washroom attached to it. There's a little bunkie, you can just see the corner of it, that's for the partner to sleep. And there's lots of space. So we can have a Hoyer lift in here, we can have a power chair, we can have a cot. There's lots of space for anything that you need in this lovely room here. When we need to do a cesarean birth, the woman herself and her family are really important participants of the birth plan. Sometimes it can be really complicated. So we do have some people who have significant medical comorbidities. This is just the setup of an OR for one of our more complex patients beforehand. And one of the things that I think is really special about what we do is when we're setting up in the operating room beforehand, you can see this gentleman in the Super Mario Brothers jumpsuit on the right there in the white jumpsuit. That's her husband. And he, we do have partners come in and help set people up in the operating room. So, this is a little bit non-traditional, but we want to make sure that, usually the person and her family are really experts in that individual's body. We worry about spasticity, we worry about osteoporosis, we have to put wedges in certain positions. When we're operating, we have to be really cautious about putting pressure on certain parts, especially if the knees need to be up and bent during the C-section. So sometimes, they're almost in a sitting position because of spasticity that's there. And we have to work around that and be really cautious. So when we're setting them up in the OR, their partner often will come to help. And I think it's good, not only from a technical perspective and a safety perspective, but I think, from an emotional perspective, it's really, helpful for people to have them with them the whole time. So I'm going to show you a baby picture. Okay, so just, in case, here we go. Here's a lovely, beautiful baby picture. So some women, for different reasons, need to be asleep and have general anesthesia during their delivery. So people who have severe scoliosis with Harrington rods, some other complications may not be candidates for regional anesthesia, and they need to be asleep. So we take pictures because we want to keep this as a happy birthday party. We usually get a tall medical student to stand with cameras and make sure that we capture the birth, or we take videos for this family. So we try to, even if they can't be present in that same way, we work really hard to make sure that that this is a really family-centered and person-centered birth experience. These pictures are so good because we actually had our professional photographer come for a story, so that's why the lighting's so amazing. But this is, I think, just a really nice birthday picture. So afterwards, we really try to focus on maintaining family togetherness. The babies do skin to skin with the mother or with their partner. Breastfeeding initiated as soon as people want to, if that's what their feeding plans are. And there are some people, for example, some people with muscular dystrophies, we need to extubate them in the ICU. And so we bring babies down to the ICU, and people are pumping and breastfeeding their babies there. So we try to really make sure, and we work really collaboratively with the ICU. So we try to keep this, a family event as much as possible. This person here, this is Sue Herman. She's our head lactation consultant, and she sees most women before they deliver. And you can just see, we call this the Joey bed, and it's like a little cot, and it slides over the bed afterwards so that the woman doesn't need to reach over, sort of twist and to lift her baby up, so her baby can be right there in front of her, and the sides drop down as well. So it's just a nice convenient way to help hold your baby early on. So one of the things I know everyone here works with people with spinal cord injury, and so this probably isn't as much of something to drive home, but I really try to enforce when I talk about our clinic is that people with physical disabilities feed and take care of their babies. So here's some wonderful families that were kind enough to share their pictures with me for these sort of presentations. And you can see, this is a woman here using a pillow to help support her baby while she's breastfeeding in her wheelchair. You can see sometimes the older babies, they kind of like crawl up, and they know how to sort of work with their mom in their wheelchair when they're breastfeeding. The woman who's standing there, you probably can't see it, but she has congenital bilateral amputations, and there she is holding her baby very nicely, and she did great with breastfeeding as well. And then you can see the woman at the bottom there, and she can't have she doesn't have any use of her upper limbs, but you can see she's doing beautiful skin to skin, which is so important for that baby in terms of temperature regulation and heart rate regulation, and providing breast milk with her husband there. And so just really lovely family pictures of people caring for their babies. We do try to do the breastfeeding support beforehand. So if people are choosing to breastfeed, they get to practice. And this is Sue with her practice dolls. So we have weighted dolls, and then the person can practice, different lying down positions, or, with wedges or pillows to see what seems to be comfortable for them, so that they have a little bit of a head start when they're trying to breastfeed afterwards. So here we have sort of, we're coming to the end of the presentation, what happens afterwards. I just wanted to share some of our lovely family photos of all our different, people with different reasons for having physical disabilities, and they're, happily parenting and spending time with their kiddos. And it's been just such a joy to be part of all of these families and welcoming all these babies into the world. And so, really in summary, I want you to know that people with spinal cord injury can have successful pregnancies, but there are specific health concerns we need to think about, specifically bladder concerns, autonomic dysreflexia, preterm birth and preeclampsia. Preconceptual counseling, again, I think that it goes a long way to have information beforehand. Interdisciplinary care, good communication are all really key. And our accessible care pregnancy clinic cares for people with spinal cord injury and other disabilities in a supportive interdisciplinary environment. There is a guideline coming out. It's coming out in July. It's the labor, delivery, and postpartum care for people with physical disabilities. So hopefully we will have some guidance soon that will be available more widely spread. And thank you so much. That's it. Any other questions about the clinic?
Thanks so much, Anne. Are you able to hear me okay?
I am. I'm gonna look awkward here, but I'm just gonna bring my speaker closer to me. All right, here we go. Go ahead.
Thanks so much. That was an excellent presentation. There has been quite a few questions in the chat, so maybe I'll go through a few of those. I mean, one you might have just addressed with your last slide there on the guidelines. There was some questions about whether some guidelines were being developed for primary care. And I guess along that lines is, how is there a way to support community OB and general practitioners who may see some of these folks, because they access the info and the expertise from your clinic?
So I think that's a really great question, because if we're only in one location, we're not that accessible. Right, so we want to be the accessible care clinic, but we're just here in Toronto. There's lots of people who aren't right here. So I mean, we are doing more and more virtual consultations, and that's just generally through the high risk clinic that we're doing more and more phone consultations with people. And so, it would make a lot of sense if someone wanted to have a preconceptual consultation, for example, and we can just do, provide that. And then provide, support for people in the community in terms of if you wanted to, do either alternate visits or just, once or twice touch base visits if needed. And then people can hopefully then deliver in their home communities if their community hospitals are comfortable with that. So I think it's I think that there's no reason why we can't, provide that kind of support. From a preconceptual counseling, and then some intermediate virtual visits during a pregnancy if it's helpful. I think that the key is the delivery piece. And our hospital, because we've been doing this and we have a team that's familiar with it. Anesthesia is very familiar. It's something that we sort of have a way of moving through in our team meetings to accommodate people. Different hospitals might not have that yet or need to be establishing that. But hopefully, with the guidelines coming out, and if people have questions about, what they might be looking for, I think there's no reason why this couldn't be done at another center. You just need to get the people together to decide this is what we're going to do. And we need to be really strong on the communication piece. Making sure everyone knows what's going on. And then, the space is great. Like I love having the really big rooms and things like that, which I think is really nice, but I think that you can still provide good care, family-centered care, whether or not the space is really big or you happen to have access to a really big birthing room, for example. So I think Zoom is the wave of the future for this.
Yeah, it's definitely changed things.
Mm-hmm.
Another question just from earlier is do you manage asymptomatic bacteriuria in individuals with physical disabilities or spinal cord injury differently than you would in a regular pregnancy?
So sorry, did you say asymptomatic or symptomatic?
Asymptomatic.
Asymptomatic. So I probably would treat it. And this is a really challenging piece because I know that it tends to, so many people have asymptomatic bacteria anyway. But we know in women who do not have spinal cord injury, there also is in pregnancy specifically, there are many more women who have asymptomatic bacteria. And that's why we screen everybody at the beginning of pregnancy, even if they don't have any symptoms. And we know that the asymptomatic bacteria does increase the risk not only of bladder infection in the future, but if you don't treat it, there is an increased risk of preterm birth. So that's part of the screening that's there. I think it makes sense to try to treat it, at least initially for that reason. However, if someone has persistent asymptomatic bacteria, I think that at some point, if they're not having symptoms, we'd have to say, you know what, you're just on antibiotics this entire pregnancy. Is that really a good thing or not, if this is not causing specific harm? I think the hard part about it, there was one small study that had 6 women where they used a cycling antibiotic regime, where they just changed the antibiotic every week based on the culture. So they just kept putting them on new antibiotics. And in that very small group of 6 people, they had no preterm deliveries. So, I think that there's not really enough data to extrapolate if that was successful or not. But you'll see if you read in the literature, that's pretty much the only study that's ever been done looking at sort of chronic treatment by cycling the antibiotic in women with spinal cord injury and pregnancy.
Great, thanks, Anne. There were a few other questions. I wonder if it would be okay if I can send them on to you, Anne, and then you might be able to answer via email, and we can.
Yeah, sure. Because I know we're coming to the end of the time here.
Yeah, but it was great to see all the excellent questions and discussion. It really brought out a lot of good questions. So a great topic. I just want to once again thank Anne for taking the time to do this. This was something that this community wanted to hear about. And then in the final couple minutes, I just want to thank everybody for attending, and just a couple quick announcements. So we do have another webinar coming up. I believe it's in February or March, and it'll be on exercise with spinal cord injury, and Dr. Jennifer Thomason will be presenting. So we'll keep everybody updated on that.
It's actually in January.
January. Oh yeah. Okay, great.
January 20th.
Awesome. And also, I want to just mention that this whole webinar series is part of an initiative that we're doing with the Praxis grant. It's a collaborative primary care spinal cord injury network that we're forming. So there will be invites to people to join this, this collaboration, this network at various levels. You will get emails about that. We'll be asking people if they have an interest to be a part of the steering committee or an interest to be part of a more general network, and that may just be, you know, liaisoning with various projects or attending webinars such as this. So I will ask people just to be on the lookout for that kind of communication from us as well. And with that, I'll just, we'll end things. And thanks again, Anne, for the excellent presentation.
My pleasure.
Bye, everybody.
Take care.